Hi, everyone. Thank you for joining us today. We're going to give it a couple minutes just to let people hop on. And in the meantime, I will make a little announcement about CEUs. And I'll make this announcement again at the end for anybody who joins late. But if you registered and requested CEUs, you will hear from me in about 3 to 5 business days. And I'll send you an email that includes a link for you to go fill out a Qualtrics and to actually download that CEU. So um, I will be in contact with those folks. Um, you should, during our presentation, you can put any questions in either the Q&A or the chat. We'll be monitoring those, but we typically do save all of those questions to the end. Um, and then Yeah, we'll give it maybe one more minute for folks to join.
Mm-hmm.
Hi, Dr. Magana.
Hello. Yeah, this looks very exciting. Yeah.
All right, yeah, I'll go ahead and pass it over to you, Dr. Magana, to introduce our speaker today.
Okay, great. Hi, everybody. Um, yeah, so this is June. I don't think we're gonna do an Autism Consortium next month, but this is probably the final one for this academic year. And so I want to introduce Dr. Hannah Phipps Rosenfield. She completed her PhD and clinical master's in speech language pathology at Northwestern University. And she's currently a postdoc fellow here at UT Austin. Her research evaluates caregiver-mediated interventions for young autistic children, targeting behavior regulation, communication, and language. And more recently, she has begun examining evidence-based trainings and early intervention providers to improve the dissemination, implementation, and sustainment of interventions in real-world clinical settings. And I think that sort of implementation, real world thing is where the field is moving and needs to go, right? In this webinar, she'll present her dissertation work in evaluating behavior support in Illinois' early intervention system, which serves as pilot data for ongoing work, examining behavior support interventions for use by all providers. And we can think about Texas from that uh, example. But I'm going to turn it over to you, Dr. Phipps Rosenfield.
Awesome. Thank you so much. And thank you for that really nice introduction. I'm happy to be here with everybody today to talk about this. I think it'll be a nice presentation. I think, like Caroline said, feel free to put any questions in the chat and then we can get to all of them at the end as well. But yeah, I'm Hannah. I'm a postdoc at the University of Texas, and I'm also a speech language pathologist finishing up my clinical fellowship year. And today I'm really here to talk to you about a roadmap for Texas, what Illinois' early intervention system tells us about behavior support for autistic children. Ooh, there we go. A bit of what we're going to talk about today. This presentation I kind of wanted to chunk into three parts, 3 to 4, I guess you could say. With the first being just a broad overview of early intervention. I know a lot of us are probably familiar with early intervention or have some experience or understanding of what it is, but I think it's always really helpful just to kind of lay the field and understand early intervention so we're all on the same page. And then I also want to specifically talk about early intervention as it pertains to Illinois. We'll talk about this later in the presentation, but state to state, it looks really different, which I find very interesting. And so something that we found in Illinois might be applicable to Texas or it might not. And I think that will be an interesting discussion point that we can get into later as well. I'm going to present to you some research that I did with data from Illinois' early intervention system. And then I would love to discuss as a group, the implications that some of these findings might have for Texas, or what Texas has done and the implications that that might have back for Illinois. And then finally, I'm happy to answer any questions about the presentation or just about early intervention in general as well. Alrighty, so let's jump in. Okay, so as I said, some of us might be familiar with early intervention, but for those of you who are not, I'm going to do a quick overview. Early intervention is a federally funded program through the Individuals with Disabilities Education Act, or IDEA. IDEA is a federal law that guarantees children with disabilities access to free and appropriate public education and early intervention services. And so, what it really does is kind of provide the funding as well as the legal framework for special education and EI programs nationwide. When we think about IDEA, we think about kind of two main parts. The first part being Part C, which is services for kids who are birth to three that address family-centered goals and provide family-based services. Then we have on the other side Part B, which is services for kids who are 3 to 21, and it really addresses education-based goals and providing those special education services. But for the purposes of today, what we're mainly focusing on is Part C, which is early intervention. While Part C is federally funded, what's very interesting is that states operate their systems on their own, so they can look very different. When we think about differences across these states, one of the largest differences that we see is eligibility criteria. So each state sets its own eligibility criteria. And so this means that when a child qualifies for services in one state, they might not qualify for services in another. So even if they have the exact same developmental profile. So the threshold for, enough of a delay really does vary state to state. Whether or not a child who's considered at risk is eligible differs state to state. And then even how the delay is measured really does vary by state as well. Another key difference that we see is service provider models. We see these models differ across states. There's two kind of main service provider models, one being the primary provider model, which is this idea where families in early intervention have one early intervention provider that provides all of their services to them. So they really only see one EI provider. And then on the back end of that, there's an interdisciplinary team that's supporting that one provider. The other service provider model is called a coordinator with independent provider model. And so what this looks like is that each family has an EI coordinator, and that person helps them kind of navigate through the early intervention system and really understand what services are available to them, help answer any questions. And then they also have individual therapists that will come and provide services for their family and their child, depending on what their eligibility criteria is. And then finally, the last difference that we see between states is provider training. So we see a lot of differences between pre-service training and post-service training. The differences in trainings that are available state to state, as well as what's required to work in early intervention. On the flip of all those differences, there are broad similarities that we also see across early intervention. One thing that's universal across early intervention is that all of the services are provided in a coordinated and family-centered approach. And so what that means is that no matter what the state the family or the child lives in, doesn't matter what service provider model their state uses, the services are built around the family as a unit, not just the child. And so what this means is that every step of that early intervention process is really including the family, and one of the biggest parts being goal setting. So we're making sure that we're setting goals in early intervention that align with the family's individual needs, and that's going to increase the likelihood that they're engaged across services and that they're using the strategies that are being taught to them. We oftentimes know that when families are in early intervention, the recommended approach is parent coaching. So the idea is that an early intervention provider provides services to the parent directly, coaches the parents on how to use the strategies, and then the parents can use these strategies outside of their sessions as well. This maximizes generalization, so making sure that these strategies generalize different contexts that the child is in, as well as dosage. So if we're teaching parents strategies, they can use these strategies, throughout their daily activities. Whereas if we're only working one-on-one with the child's really only getting that 1 hour of services. And then finally, the last thing that's similar between states is the developmental domains that are targeted in early intervention. So you can see these on the left here. There are 5 core developmental domains that are targeted in EI. The first being adaptive skills. So you can think of this as self-help skills or daily living skills, feeding, dressing, toileting. Our next domain is cognitive skills. This is thinking, learning, and problem solving. We then have communication, which is the understanding of others and being able to express your wants and needs. We have physical skills that are targeted. So that's going to be our fine motor and our gross motor. And then finally, we have our social emotional domain. So this is the idea of, relating to others, regulating your emotions, building relationships. And we'll get into this later in the presentation, but this also encompasses interfering behaviors. So reducing some of these behaviors that children might engage in as they are moving across development and reducing those behaviors to optimize learning opportunities as well. So that's my very quick overview of early intervention when we think about it kind of at the national level. Now I want to pivot to talking about what this looks like in Illinois specifically. As I alluded to earlier, it does look very different state to state. I've spent the last 7 years in Illinois, so that's what I'm really familiar with. I just moved to Texas in August, so Texas is a newer early intervention system for me, which I'm really excited to learn about. But mainly today, what I'm going to be talking about is the early intervention system as it pertains to Illinois, and then our broader discussion will think about the implications for our findings. But when we think about Illinois, this is the eligibility criteria for early intervention. The first is that kiddos have to be between the age of birth to 3. They need to be diagnosed with a disability or have a 30% developmental delay in one or more of those areas. Again, those are those 5 core domains that we just talked about, or they're at risk for a significant delay. When we think about the service provider model, Illinois uses a coordinator and an independent provider model. So what that means is that families enter the system by contacting their local child and family connections office, or their CFC. You'll hear me refer to that a few times in this presentation. You can see on the map, sorry, it's a little bit blurry. I couldn't find a great one. This is the state of Illinois, and it's divided up into 25 CFCs. This is where families go when they're entering the early intervention system, and they help them kind of throughout the early intervention system process. And it really is delineated based upon where you live. Contact your CFC, and your CFC connects you with a service coordinator. That's that kind of main point of contact that you have for your experience in early intervention. And that service coordinator really does kind of advise and oversee all the services you receive from those individual providers who provide therapy based upon the family and the child's needs. In Illinois, when we're talking about those specific providers, those are going to be like our speech language pathologists, or our SLPs, our occupational therapists, or our OTs, our physical therapists, or our PTs, or our developmental therapists, sorry. And that's our generalist, our DT. I've alluded to this a little bit, but this is the timeline for what early intervention looks like in Illinois. I want to take us through this just so that we kind of understand what entering through a referral in early intervention would look like in Illinois, all the way to the transition out of early intervention in Illinois. So I already mentioned this briefly, but oftentimes what happens is a parent or an adult in a child's life contacts a CFC for an initial referral for early intervention, and then you get connected with your project coordinator, which is going to be and they're going to do your intake. Your intake is going to be really setting you up for your initial evaluation, which is done with a variety of EI providers to assess the child's development across those 5 domains. So again, that's adaptive, communication, cognition, social, emotional, and physical development. Once that evaluation is done, the providers determine whether or not you meet eligibility criteria for early intervention. And if you meet eligibility criteria, you then move on to a meeting, which is a Individualized Family Service Plan, or an IFSP meeting. During this meeting, again, it's going to be your coordinator, your initial evaluation team, and the family coming together and talking about, okay, you are eligible for early intervention. What are the goals that we're going to create, and what are the services that you're eligible for? This creates an IFSP document, which is a legal document that the family then can take with them throughout their early intervention process. They're then eligible for services. In Illinois, you receive services again from those individual EI providers. Your IFSP is reviewed every 6 months, seeing if you need to adapt or change any of the goals or add any services. And then finally, when the kiddo hits 3 years old, they'll transition out of early intervention. So I know that was a very brief and quick overview of early intervention. I just wanted to kind of give us kind of a lay of the land for what it looked like at the national level as well as in Illinois. I'm going to transition over now to talking about a research project that I did, which is with data from Illinois' early intervention system, where we took a look at behavior supports for autistic children and what this looks like in the early intervention system in Illinois. As we move through this, I do want you to keep in mind that states look super different. So some things that I talk about might not pertain directly to Texas, but I think that this is a really nice opportunity and something to keep in the back of our mind that we can discuss more at the end later. Okay, so when I'm talking about behavior support, it's oftentimes behavior support for interfering behaviors. So interfering behaviors are really important because we see them at elevated rates in autistic children compared to their non-autistic peers. There's a lot of terms out there to describe interfering behaviors. So you may have heard of other terms such as problem behavior, externalizing behavior, disruptive behavior, challenging behavior. These are all terms that are really getting at the same construct. So I'm using the term interfering behavior, and when I'm using that term, it's a blanket statement for really talking about things like frustrated vocalizations, physical aggression, not completing tasks, and eloping. What's important about these behaviors is that they are one of caregivers' primary concerns when they enter early intervention. So it is oftentimes a concern that caregivers have and that they express to us when they are entering early intervention. And so not only is it important from the standpoint of it's a caregiver priority, we oftentimes see it in this population, but we also know that when we reduce interfering behaviors, we see positive development across a variety of domains. So we see it across communication, across language, across peer relationships, and across academic outcomes as well. We have seen this before. I won't make us go through this again, but I put this here to kind of remind myself. I want to note two important parts of the early intervention timeline in Illinois and as it pertains to this project, one being the initial evaluation and the other being that IFSP document. When I'm talking about how we're identifying interfering behavior, and we'll get to the point where we're talking about data collection and methods as well, it's from these two documents. So I did want to highlight that here, just making sure that we're understanding that this is the part of the data that we're actually looking at. So again, that initial evaluation document is looking at the child's development in that moment and having a really nice comprehensive document that looks at their medical history, parent concerns, informal observations, their assessment scores, and ultimately their recommendations for eligibility. And then that IFSP document has their EI goals, their strategies, and their services that the family and the child receive. So in Illinois, autistic children that engage in interfering behaviors might receive early intervention services from behavior-specific EI providers. So it might be that on their IFSP document, they have a goal for these providers, or these providers are explicitly listed to target these goals or strategies. And so when we think about our behavior-specific EI providers, these are our providers that have core training in social emotional development and interfering behaviors. And so these are going to be our licensed clinical social workers, our board certified behavior analysts, and our clinical psychologists. What's interesting about Illinois specifically is that we have fewer of these providers compared to other providers. We have significantly fewer of them. And these other providers do not have core training in social emotional development, but we know that they report working with a lot of children that engage in interfering behaviors. And we know that early intervention is expecting them to have that general knowledge of those 5 core domains. And so when I'm talking about these other EI providers, again, those are going to be our developmental therapists, which is our generalist in Illinois, or our DT, our speech language pathologists, our occupational therapists, our physical therapists, and our nurses. And so we as a field need to really be thinking about, okay, how are we providing trainings for all EI providers, knowing that some have core training in social emotional development and interfering behaviors, but not all. And we do know that all of these providers are working with children that engage in these behaviors. And so due to this mismatch, this mismatch in the number of providers available, as well as the training and the pre-service knowledge that a lot of these providers have, Illinois is already thinking about how can we best support these people. So supporting not only EI providers, but also supporting families and children in the EI system. And so what Illinois did is they created what's called a social emotional EI component. So it's a component that was added on to early intervention, which includes specific supports from a social emotional consultant, so a very specific EI provider. What's important to note is that there's only one per CFC, so there's only 25 of these providers currently in the state. Um, but what's really cool about this new program is that SE providers are really there to support the system as a whole. So they can provide professional development to other EI providers, consultation services, and they can also ultimately support social emotional screening and assessment. An early intervention provider can qualify as an SE consultant if they have a master's degree in child development, special education, psychology, social work, counseling, or a field that's related to one of those areas. And so this is a really new idea and it's very specific to Illinois, but we don't know a lot about this program. We know it was rolled out, we know that it's new, but we don't know how these social emotional consultants are really functioning within early intervention as a whole, whether or not it's successful or if we need to make any adaptations to this program as well. And so this is kind of my long overarching intro that brings us to the current study and the current research question. So given all of that, we were then really interested in taking a look at how were children's interfering behaviors, interfering behavior goals, and behavior support strategies and eligibility for behavior services documented within those initial evaluations and those IFSP documents. We were also interested in taking a look at how social emotional consultants were documented within those documents. And then we wanted to see which types of EI providers were most likely to be listed to implement behavior support strategies. And then we were very curious about which specific types of providers are most likely to be listed to implement a specific subset of these behavior support strategies. So we're interested in looking at compliance training, daily or visual schedules, prevention strategies, or reinforcement. And we'll get to why those strategies are important once we go through the results a little bit. So I will come back to that. In terms of our methods and our participants that we had in this study, this is secondary data from a larger IES grant. So in total, for the analyses that I'll present to you today, we're looking at 184 families who were in the early intervention system in Illinois. Participants were between the ages of 12 to 36 months. The child had an autism diagnosis, and then the family provided us their initial evaluation and their IFSP document. Again, when we're taking a look at the initial evaluation, the IFSP document, that evaluation has those kind of like broad strokes developmental findings in terms of parent history, medical history, observations, and assessment findings, and ultimately eligibility. Whereas that IFSP looks a little bit different. This is a shorter document that's comprised of their goals for early intervention, the strategies that will be used to reach those goals, and then the services and the providers that the child will be working with in early intervention. In order to answer these questions and extract data from those documents, we had to create a code book. So we used a deductive approach and followed these 5 steps. We selected 20 initial evaluations in IFSPs and went through a standardized process to iteratively develop this code book until we found no new content themes. I'm happy to answer any questions about this process. I'm also happy to share this code book if anyone is interested, but I just wanted to be just give you a little bit of a look and see how we created our code book for this project. Ultimately, this is a very pared down version, but this is what our code book looked like. Overall, throughout that iterative process, we identified 7 interfering behavior categories, which you can see here on the screen. Additionally, we found 7 behavior support strategies. And then we also coded all of these documents for whether or not the child had an interfering behavior goal, whether or not the child was eligible for behavior services, what providers they were eligible for, and then was a social emotional consultant reported in their documents as well. And again, this is very bare bones, but I'm also happy to share the code book if anyone is interested in that as well. Okay. So our findings. So again, for our first research question, we are interested in taking a look at children's interfering behavior, their interfering behavior goals, and their behavior support strategies and eligibility for behavior services within these initial evaluations and IFSP documents. We found that across 82% of these documents, interfering behavior was reported. So in 82% of our 184 sample, we found that the interfering behavior was reported as a parent concern and reported as something that they noticed with their child, which is not unexpected. We know that this population of kids does have higher rates of interfering behaviors. Now, what was very interesting is that from those 82%, only 11% of these families had a behavior goal to address that behavior, and only 15% were eligible for behavior services, which is very striking. Those numbers are very different. Another thing that we found that we thought was interesting was that there were still, however, behavior support strategies nested in the IFSP, meaning that the goal might have been pertaining to a different developmental domain, but they're suggesting use of behavior support strategies to target that goal. And so we did see that behavior support strategies were reported somewhere in the IFSP document across 84% of our sample. For our second research question, we took a look at how are social emotional consultants documented within initial evaluations in IFSPs. What was very interesting is that social emotional consultants were never mentioned in initial evaluations, and they were only mentioned in 12% of IFSPs. So we're seeing a very low number of these documents actually reporting a social emotional consultant. Across the 12% that did have a social emotional consultant listed, interfering behavior was reported 91% of the time. The families never had a behavior goal, never had eligibility for behavior services, but we are seeing, again, those nested behavior support strategies in those documents. So a similar trend to what we found from our first research question as well. Our next question that we were interested in evaluating was which type of EI provider is most likely to be listed to implement any behavior support strategy. So again, we had those 7 behavior support strategies. When a behavior support strategy was listed, so the 84% and the 77%, the following EI providers were recommended to implement such strategies. 86% of the time it was an SLP. 84% of the time it was a DT, that's our early intervention specialist, and 65% of the time it was an OT. And then we see a massive drop. We see that 6% of the time it's a social worker, 5% of the time it's a PT, 2% of the time it's a clinical psychologist, and 2% of the time it's a nurse. And so what's very interesting about this is those higher percentages, the 86 to 65, those are our other providers who are not trained in behavior support and don't have core training in social emotional development, yet they're the ones who are being recommended to use these behavior support strategies. So that's a very interesting kind of mismatch that we're seeing there as well. And then for our last research question, we were interested in taking a look at which type of EI provider is most likely to be listed to implement the following behavior support strategies. We took a look specifically at compliance training, daily or visual schedules, prevention strategies, or reinforcement. So 4 out of the 7 that we coded for. This is done because of just pure frequency count. So these strategies were listed much more frequently than some of the other strategies. So due to model fit, that's how we modeled this. And in addition to that, we're only looking at these differences between those other providers that were listed at those high frequencies. So again, our SLPs, our OTs, and our DTs. So what you can see here is a mixed effects logistic regression model. And what we're seeing here is that across daily or visual schedules, across prevention strategies, and across reinforcement, we're not seeing statistically significant differences between EI provider type. But we did see statistically significant differences for compliance training. And so we're seeing these differences on the first highlighted red box where it says DT/OT. This shows that DTs were 80% more likely to be suggested to use compliance training than OTs. Then if you go down to the SLP and OT, this is showing that SLPs were 84% more likely to be suggested to use compliance training than OTs. And then if you look in the middle where it says DT/SLP, this is showing that there's no statistically significant difference between DTs and SLPs when it comes to being reported to be using compliance training. And so this was kind of puzzling to us. We weren't really sure why we were seeing differences for compliance training, and we wanted to understand a little bit more as to why. And so one possibility could be that there are just fewer children who are qualifying for occupational therapy services compared to SLP and DT services. So if this is the case, it might just be that OTs are listed less frequently just because kids aren't eligible for their early intervention services. So we did a post hoc analysis where we evaluated how compliance training differs among EI providers for children with interfering behaviors that were listed in their documents, as well as they were eligible for OT services. And so once we pared our data down in that sense, we conducted a chi-square goodness of fit test and found that there still were significant group differences. So this shows that even when children are eligible for OT services, they're listed less frequently than SLPs and DTs to implement compliance training. Okay, so main takeaways. I know that's a lot of data. I know that's a lot of numbers. So broadly, what we found is that in 82% of EI documents, interfering behavior was reported for autistic children. However, in less than 10% of these documents, was there a goal to address this behavior or eligibility for behavior-specific services from a behavior-specific provider. When we took a look at that social emotional consultant, that new program in Illinois, we're not finding a lot in these documents. They were never mentioned in initial evaluations, and they were only reported in 12% of IFSPs. So we're still not getting a great picture as to how these providers are really functioning within the early intervention system in Illinois. And then in 84% of these EI documents, there were those nested behavior support strategies, but they were oftentimes assigned to an EI provider who's not trained to address social emotional development. So again, that's our SLPs, our DTs, and our OTs. We saw statistically significant differences in compliance training, and then we dug a little bit further and found that it was a true difference, such that DTs and SLPs were more likely to be suggested than OTs to be implementing compliance training strategies. And we can get into this a little bit more in our discussion, but a large part of that finding we think is just kind of scope of practice. Compliance training really does fall into more of these kind of following directions, completing tasks, and occupational therapists oftentimes really are working on autonomy and really those individualized skills. And so sometimes the mismatch in kind of theory of practice and scope of practice can be really apparent when we're looking at those strategies. In terms of our future directions, we have future research ideas as well as future clinical ideas. For research, we're really interested in examining how children's interfering behavior presents within EI therapy. I think the one limitation or a limitation to this study is the fact that we're just looking at documents. We're not actually looking at the, interaction that's happening during the initial evaluation, during the IFSP, during EI therapy. And so I think that's a really nice step to actually see how this behavior is presenting within the early intervention system. And then also to further understand EI providers, their understanding and implementation of these behavior support strategies, specifically for those providers who are those other providers who don't have the training, but they are listed to be the ones who are supposed to be implementing those strategies. And then the next kind of step for us and more concrete idea that we have for a grant application would be an adaptive design within implementation science to really tailor existing behavior support interventions for all EI providers. We already have a lot of behavior support interventions. They're just oftentimes taught to those behavior specific providers, even in pre-service or post-service training. And there's no reason why those trainings shouldn't be extended for more providers to have access to those strategies so that we can better serve the families and the children in early intervention. And I think an interesting part to this really could be considering how other states are doing this. If other states already have these kind of interdisciplinary trainings for everyone when it comes to behavior supports for kids in EI. In terms of clinical future directions, kind of what I just said, but in a little bit more of how can we actually have this in real world context is creating these trainings, making sure that we do have available evidence-based trainings for all EI providers when it comes to behavior supports for kids, because it's not that these kids are only showing these behaviors in their sessions with behavior-specific providers. They're oftentimes showing these behaviors across sessions, across contexts. And so most adults in the child's life need to have adequate evidence-based strategies to respond or prevent these behaviors. And then continuing to develop that social emotional consultant role. I think it's a really interesting idea. I think Illinois has, they're starting to kind of target this gap, but I think that more can be done, and we could probably learn more from other states in what they're doing as well. I want to give a brief thank you for everyone who helped with this research project. It's a very large study, and so I want to thank my doc advisor, Dr. Megan Roberts, who this is her larger grant, so she was very generous in letting me analyze a subset of it. And then Dr. Lauren Hampton, who's also here at UT, is my postdoc mentor and was on my dissertation committee as well. They were really key parts in coming up with the idea and then seeing the project all the way through. Always thanking a funding agency because funding is oftentimes few and far between. So a big thank you for that. And then ultimately the families who participated and shared all of their information and data with us as well. I'm going to open it up to questions, but I also am going to leave this slide up here. I think it would be really interesting to have an open dialogue and discussion about how we can kind of think of these findings as they came from Illinois' early intervention system and really think about how they might generalize or even we could learn from Texas. So my first question is, in Texas, what behavior specific support? So you can think of these as like trainings or manuals are available for EI providers and parents and what has worked well and maybe what hasn't, as well as where do providers turn when a child's needs exceed their training. So I'll leave those up there, and then I'm happy to answer any questions as well.
Yeah, those are great questions. I'd like to learn. I'd like to know the answers to these too. I don't really know actually, but if anybody knows much about the EI program in Texas, we'd love to hear from you. And feel free to put any comments you have or questions in the chat, um, or just raise your hand and speak out. Hannah, do you know which model, you presented some models at the beginning that vary across states. You know which model is used in Texas?
Yeah, it is reported that it's the primary service provider model. My lack of understanding is that I don't fully know if this is a model that is required or a model that is recommended. So when we talk about the primary service provider model, I do believe that that is what Texas has, but I'm not
Mhm.
sure if all families are adhering to that model. I
Mhm.
know that Texas also has what's called a cost sharing model, and so Texas works through like large private companies to contract out for EI, whereas Illinois, they are like they're not state employees, they're like independently contracted. And so that's why the
Yeah.
CCs function a little bit differently. And so I think that there is a bit of an interaction there too of like the provider model that you have and then like the payment insurance model that you have as well. And very transparently, all of that is very confusing to me. I'm not sure if it's clear to others, but I know that there's a lot
Yeah.
of like nuance to those models as well.
Yeah, because I was wondering about the independent contractor versus organization, because I know in Texas some of the organizations are that at least around this area are Any Baby Can and Blue Bonnet, I think. Also Easter Seals.
Yeah.
Yeah, so those are some of the probably the main providers. There may be others, but yeah. And it might be that our participants are just learning about EI. They may not be working in that field, but it's good to know about these services and that they're available and
Yeah, and I'm happy. I'm not sure I didn't do this, but I'm also happy to leave my email and we can send that out. I think it's maybe in there as well. So if anybody has any questions later on, you can also feel free to email me. I'm happy to answer them too.
right. Um, uh, Heather Becker raised her hand, so I think, do you have to let her speak, Caroline?
Yes, now she is able to.
Okay, go ahead, Dr. Becker.
You are unmuted, but we can't hear you right now.
If you prefer to put your question in the chat, you can do that too.
Yeah, okay, I'll do
Here
that.
you are. We hear you now.
Oh, we
Yeah,
hear you
yeah, you're
now.
hearing me? Okay, fine, because I was unmuted and I wasn't sure what the problem was. So as I said, as Sandy and other people know, I'm not an intervention provider. I'm a person who does program evaluation work, and that's why I was intrigued by the topic that you were working on, that you were going to present on. So my questions may be like totally in left field, or they may be part of the bigger study. And if so, feel free to tell me that, that's really not in, in the ballpark you're in today. But when I see things like there's a new person with a new position that you have in Illinois, one of the things that always intrigues me is when those kinds of new people appear on the scene, what do other providers think about that? And what is their reaction? Are they actually using this person? How are they using this person? I've seen, in Texas, sometimes when new things were introduced, that providers, existing people just frankly didn't use them very much. So I'm a little curious about that. I'm also a little curious about what family's perspective is. If I understood your presentation appropriately, it seemed like, you were making a point about who's providing the services and what kind of training they have. What I would be interested in knowing is how do the families respond in terms of the provider who is providing the services to them. So I'll just stop there.
Yeah, those are really wonderful questions. I don't have answers, but I have like musings, which I think is always great for discussion too. It is not a part of the larger study, but it is something that I really want to look at is, yeah, exactly what you're getting at is that interaction between this new social emotional consultant and the rest of the EI system as a whole. Because these are just documents, we're really just looking, okay, was this person named as someone who was in this meeting? And so that's what that 12% is that in 12% of IFSP meetings, the social emotional consultant was there. And I'm so curious to know what those conversations look like because they're coming in as this new provider, this new resource. And I don't know how early intervention providers are responding to that. And I think that that would be a really interesting, kind of interaction to look at and evaluate to try to understand how can we strengthen this or how can we change this or is it just working well? We just don't know. I think the 12% is really indicative of the fact that we only have 25 of them. There's only one per CFC, so they can't be at every single meeting, but it does seem like they're only at a low portion of meetings. So I'm also very curious as to why they are at those meetings. What about that child or that family was so indicative that they were like, okay, this is when we need to have the consultant there. I think that's a wonderful question. And then to your other question about parents, that is something that we are submitting a grant that's due in 4-ish, 6-ish days. And one of the things that we're really trying to get at is parent perspectives. I am not sure if parents have, biases towards what providers they like or don't like. And I don't know if it's based on training or based on personality or based on rapport. There could be a variety of reasons, but I think also having the input from the families and really understanding, okay, what works best for you and who is teaching you these strategies in a way that resonates best for you. But yeah, I think those are really important things to evaluate if this is a program that we're going to continue to devote time and money to. But yeah, really, really great questions.
Well, thank you for your presentation. Very interesting.
Yeah.
All right. Yeah, so if anybody has further questions they think about later, you're free to email Dr. Fit Rosenfield. And yeah, and I guess Caroline, I'll turn to you to wrap things up.
Yeah, absolutely. So as I mentioned at the beginning of our webinar, if when you registered, you requested CEUs, I will be in contact with you in the next 3 to 5 business days. With a link, an email and a link to complete that CEU and download it as well. As Dr. Magania mentioned at the beginning of our presentation, this is our last Autism Consortium webinar for this year, this academic year. So yeah, thank you very much for hopping on, everybody, and thank you, Dr. Phipp Rosenfield, for sharing some of your work.
Awesome. Thank you so much.
Right.
Yeah.
Thank you, everyone.
Bye,
Bye-bye.
everybody.